Welcome to the Health System CIO Show. I'm your host, founder, and editor, Anthony Guerra. On today's episode, I'll be speaking with Dr. Elias Kikano, Division Chief for Imaging Informatics and Medical Director for Health Informatics at Emory. Dr. Kikano, thanks for joining me today.
Thanks for having me, Anthony. Excited to be here.
All right, great. Do you want to start off by telling me a little bit about your organization and your role?
Sure. Yeah. So as you said, I'm division chief for imaging informatics, overseeing a lot of the operational work around all of our imaging applications, particularly for radiology, and we'll look over things for heart vascular imaging and all of our enterprise imaging needs. Oversee a team on from the technical side as well as on the operational side and how we deploy these apps to our efficiently for our radiologists and other end users. Also thinking about AI strategy and how that's mixed into things and layered, especially with imaging being a major player in the AI space. We're involved a lot with that deployment, strategizing, and then post-deployment monitoring. So all of that's kind of on our umbrella. Emory's a large organization, the university component on the School of Medicine side, but the healthcare side is comprised of 11 plus hospital systems. We do over 1.5 million imaging exams annually across the system. So all specialties are covered, lots of volume throughout the system.
All right, very good. So, interesting about Emory, and I covered this a little while back, is a big Apple shop, using a lot of Macs out there, which is pretty unique in healthcare, but compelling I'm a Mac user and an Apple fan, so I personally get it, and the quality of the products is really nice. Um, but I remember having discussions with your folks over there about moving in that direction. Uh, so you do have that sort of unique approach. Tell me about that. Tell me about your involvement with that, if there was any in that rollout, that decision-making process, or your thoughts simply as a user of these kind of products.
Yeah, it's an exciting time. I've definitely been a user of Apple products for a long time, embedded with the ecosystem, so very familiar. In my current role, I'm one of the lead physician informaticists that is involved with the Apple device rollout and deployment and design at Emory across the system. So that includes our Mac footprint, as well as mobile devices. So we've been working on this for a long time at Emory and definitely have been a pioneer in this space, particularly with Apple devices in healthcare. You may have noted last year, we successfully deployed at one of our hospitals, or at Emory Hillandale Hospital. It's powered by Apple devices throughout the system. There in that hospital, I believe over 85% of the devices are Apple devices, from the Mac computers in mobiles on the carts in the ICUs, in the clinic spaces, front desk spaces, provider use cases, nursing use cases, mobile devices as well were deployed there. So it's exciting to have that sort of innovation. We've seen a lot of different outcomes from user satisfaction ratings, decreased ticket volumes from the IT side of things. And then we did have a lot of, it builds kind of our resiliency across the system to have, a diverse ecosystem of devices. We've had real life scenarios where, Windows devices go down throughout the system. You may remember the CrowdStrike incident. We
Yeah.
were heavily impacted by that, but during that incident, all of the Apple devices were intact and usable. So we, rapidly deployed those in critical real time. But it increases our resiliency that if one kind of operating system is down, the other one is up. That we're able to do that and increases our flexibility. So that's been a big win for the system. So excited to be involved in those initiatives, and it's being a pioneer at Emory.
Yeah, so I think there was a feeling, or there is in some quarters, that Apple was not for the enterprise, and that's why we haven't seen a lot. But you're sort of dispelling that. Um, it's gone well. I mean, everything's gone well. There's people, I guess, had or have reservations about these kind of rollouts with Apple devices, but it seems to have gone well.
Yeah, overall, a positive results, certainly change management that we expected, as with any new types of change in the system. But surprisingly, we've had very good results and outcomes throughout by a number of different metrics, as we kind of mentioned. And then to your point, yeah, Apple's in the enterprise in a lot of different spaces, but it's kind of been slow going in the healthcare space. I think um, one of the biggest things was kind of the security component, and evaluating that. But been fortunate to work with some teams on some of the security and establishing a new baseline for healthcare, which is also very exciting news.
Yeah, so let's get into that. Let's get into that news piece and help me understand if this is really at its core what we're talking about here is an Apple cybersecurity story, or is it also an Apple imaging cybersecurity story? So you take us through the news of
Sure.
what you've done, the post that caught my eye. Help me understand. I've heard of HICP, the cybersecurity best practices. I know about the people and the or entities involved with bringing that to light and creating that. But this is the first time I've seen Mac and imaging dovetail with that production.
Yeah, it's all of the above. So take us back. There's a open source project called the macOS Security Compliance Project. It's kind of a joint initiative between the National Institute of Information Technology, as well as representatives from Apple and others that get together and essentially have mapped a lot of the control points that sit in the Apple ecosystem, with mostly on macOS, but they are universal now with iOS and iPad OS and other Apple devices, to basically set the controls and say map their controls to meet the requirements that are strict for federal agencies. For example, they follow security and privacy controls and noted in documents like 850 and 800-171. There's Defense Information Systems Agency, or DISA, that also has requirements for any devices that are deployed, in federal or security environments. So it's an open source project, again, that's mapping those control points in the Apple ecosystem with those published requirements to be able to safely deploy those devices in a secure environment. And they can be basic things that we all sort of think about in the cybersecurity space, such as enforcing password management on a local device, um, network restrictions. But it goes a little bit beyond that too, because of Apple's ecosystem. You can set control points to say, for Apple Intelligence features, to make sure that those stay on device versus going up to the cloud if you have sensitive data. So there's hundreds and hundreds of available security points, and this has been an established project for a number of years, going back again for federal agencies and security points. But no one has really done this for healthcare, and so we had an opportunity, given our experience at Emory with this. I collaborated with, heavily with my internal teams, Jane Millsap and Ryan Ritchie, who are on the IT side with me at Emory, and work with them hand in hand on deploying these devices locally in our practice. We worked with the, representatives from NIST and Apple to map the control points that are available in Apple with those that are in the healthcare industry cybersecurity practices document for medium and large care healthcare organizations, that's published by the Health and Human Services Division. So this is really the first time that we've taken kind of the evidence that is there, that is published by Health and Human Services, with the Apple device mappings, and created this essentially healthcare security baseline that any healthcare organization can reference and say, hey, if we're thinking about deploying Apple devices in our healthcare space, they can use this as almost as a reference or guide point for them to get started and jumpstart with, deploying these devices with secure control points that meet their needs.
So I guess this was something in a sense that was missing, or a point of comfort for organizations that were possibly interested or are interested in rolling out Apple devices. This may have been a missing piece that possibly was holding them back, a certain thing where the non-existence of it gave, it's just not there. Like, I would love for this thing to have been done, and this is what you've done. So you've created this crosswalk or this demonstration that shows that sort of lining up these devices with cybersecurity, healthcare specific best practices. So this is another step that may give people more comfort who are interested in moving down the Apple road. Does that make sense?
100%. Yeah, it gives them kind of a place to start where they may not have, had one before. So, many CISOs and others in the space will be very familiar with some of these
Yeah,
published security practices that are there again for federal agencies and other places. But healthcare is its own beast, right? And so
yeah.
has different things to contend with, and different compliance guidelines. And so many of them are managing these devices, and deployments based off of, best practices or maybe not established published ones. But this really helps to, give them, a baseline to start with, something that they can look at and say, in our mobile device management software now, it's again an open source project. They can pull down these control points and give them a jump start instead of having to map everything one by one manually and figure out, is this control point right for us, or is it appropriate for our institution. They can basically start with this healthcare baseline now, and adjust to meet the needs of their local organization. So it's going to be a big win for these organizations to standardize.
Anything imaging specific in this work?
So this applies to all devices in the healthcare system. So we do a lot of imaging. We use a lot of devices for the imaging workflow, whether that's mobile devices for our technologists to capture images on, or work through their patient list, and also for thinking about a future state, where we are deploying devices for medical imaging interpretation. A little bit in separate news, there was also Apple released some new devices earlier this year, one of them being the new Studio Display XDR, which is FDA cleared for medical imaging interpretation, in the United States. Now there is a way essentially to have a full hardware end to end with Mac devices with the Studio Display XDR to do medical imaging interpretation. And that's something we're currently exploring also at Emory, where again, now what was once a barrier in terms of hardware and medical imaging certification, now that's available, and medical professionals can use this Apple hardware to interpret medical images on. So it dovetails nicely with this because we can not only have a baseline to secure these devices and meet the security needs of the healthcare organization, but the hardware, and displays now meet the needs, for regulatory reasons to interpret medical images. So we really are getting to a point where Apple devices can be, on paper, universally used throughout the system.
Excellent. All right. Let's talk a little bit about enterprise imaging. Um, I've been sort of keeping my eye on it, I would say, for a number of years. It moves sort of in fits and starts here and there. Individual projects at some organizations seem to really get into it and take it on, but there are most places it seems like not much is happening. And it's just odd to me. And I have my theories about it that it's very complicated and complex, and there are other things to do. So kind of if it's working,
Right.
if nothing's broken and everything's working, like that's a big bear I don't need to touch unless, and I'm speaking from the perspective, I'm putting myself in the shoes of an IT executive saying, I got lots to do. There's plenty going on. That seems to be working. If nobody's knocking down my door and asking and saying, "Hey, we've got problems. We need your
Right.
help. We need technology. You have to help us change things here." If that's happening, sure. If there's high influential clinicians that are saying, "I can't see the images I need to see. This is hurting patient care. This is a problem," or if there's patients complaining, then IT could certainly move behind it. But to be the mover, the prime mover, or at least to try and get things moving, I don't think that's happening very often in healthcare. I don't know if it should, maybe it shouldn't. But what are your thoughts on, you could tell me a couple things, where you are in your journey, what you've accomplished, what's yet to be accomplished, what's on the roadmap, and perhaps your thoughts on my observations. First of all, do you agree or disagree with this sort of spotty advancement here and there, and my thoughts as to why that may be the case? So I'd love to hear from you.
Yeah, no, all great points. And certainly, we're making some strides at Emory. So we have a relatively robust, enterprise imaging strategy. We've consolidated all of our, radiology images in one central place, that includes some of the OR imaging as well that, funnels there. And we've been live actually for a little while with our digital pathology solutions as well. So that's another area that's, up and coming and has a increased adoption, but we've consolidated that all in the same platform as our radiology, which has been a really big success. We do have a separate, cardiac imaging system that's available and is used robustly, but that's another thing that we're critically looking at as another area of potentially consolidation and bringing that into the enterprise imaging fold. Then you have so many other things, right? So medical imaging is, radiology is one of the biggest primary volume drivers, but so many other things, visible light imaging, whether it's derm imaging or others. Ophthalmology imaging is another huge area. So there's a lot of opportunities, as you said, to, where medical imaging could be consolidated. And I agree with your points. I think it's if it's not broke, people say don't go out there and try to fix it. They're not getting complaints. It's there, but um, you know, a lot of places will this introduces more complexity in the system. So you have a lot of more points of potential failure or potential to fall behind in terms of innovation if you're imaging and is siloed in different areas or using different applications. So I've seen different approaches to it. One can be they try it, an organization will try to do an enterprise imaging approach where they really just want to consolidate down to the least number of vendors and, whatever is possible to reduce complexity, which is good because then, you're consolidating things, you're simplifying your platforms and potentially providing a good, experience for the users and decreasing and ultimately for patients to be able to access their own images in one central place. The other camp is around, using the best possible, solution for that specific specialty, which I also agree with in certain spaces, right? There's not one vendor that I've seen anywhere in space in the imaging space that can do 100% of the capabilities needed for every single specialty, which is why, you'll have certain gaps for, post-processing of images, or you still have these third-party vendors that are still very thriving in the way that they, analyze images and, are able to do advanced post-processing and advanced interpretation. So there's still going to be a need for those. But can you get to a point where it's kind of a balancing act, essentially? Can you get your enterprise to a place where you're on the least number of, vendor platforms, as an example, that covers over 80% of your use cases, and then you leave, some of those very niche and specialty cases that are maybe smaller volume, but very critical to the mission. You leave those in their specialty silos, and make sure that those connections are robust between the systems when you need integration interface. I think it's really just around whatever approach you take as an organization. It's just important to have an overarching, and comprehensive theme or understanding of what systems are out there, so that you know where the nuances are and what the overall strategy is. I think the ones that will be in trouble is where they leave these fractured ecosystems and not be able to, keep up with the pace of innovation, particularly with all the AI boom that's happening in the imaging space. You want to be able to leverage that and increase the efficiency across the organization. And it'll be challenging if you have, 5 different pack systems all on different versions and different servers and different integration points when you're trying to reach deploy new things.
All right, great. So lots of good stuff to get into there. One of the things that I really wonder about, I'd love your feedback on, is the role, as I mentioned in a little bit of my theorizing, the role of IT executives like CIOs and CMIOs in a health system, a large health system. What is their role, in your opinion, in the enterprise imaging dynamic? Should they be initiating conversations? If so, with who? Or should they merely be receptive to requests for support, users identifying problems, and then be willing to jump in, learn more, and try and support? Which way what do you expect? What do you want from your CIO or CMIO? Uh, your thoughts?
Yeah, I work very closely with my CIOs and CMIOs in the institution, and I'm grateful to have their partnership and support, especially in a lot of the imaging initiatives that we bring to the table. And they're aligned in the strategy that we're taking, at our organization. So excited about that. And I think the biggest advice I would have for other executives is to listen to their stakeholders, right? Bring on imaging experts in the space, whether it's a partnership between the physician informatics space, those who have subspecialty experience in this, like radiology, heart and vascular imaging specialists. Each of those need to be brought to the table, as well as your having IT specialists on the team that are really dialed into imaging and enterprise imaging in particular. The medical imaging is just growing in volume year over year. There's no stopping it. We have a shortage of radiologists across the entire country. We're not training enough radiologists. There's so much demand for imaging volume. I think anyone can speak either from personal experience or any interaction with the healthcare space that no interaction in patient care is absent of some sort of medical imaging, whether it's an ER visit or outpatient follow-up medical screening. There's always medical imaging involved in every single touch point there. And I don't think that's going to change, especially as imaging modalities continue to advance. They get more accessible and more ingrained in the clinical pathways. So really important for chief information officers and medical information officers to be in touch with medical imaging and how it's what their current state is in their particular institution, and be forward looking, right? Because again, as these volumes continue to grow, as demand continues to increase in these services, they really need to be thinking about what's their current architecture, what does it need to scale in the next 1, 3, 5 years, 10 years down the line, making sure they're setting up their systems for success and bringing stakeholders to the table that are subject matter experts in the state. I think it's good for them to have individual knowledge about it and how it interacts with the rest of the EHR and other medical systems. But it's such a big space in and of itself. Having experts at the table is going to make a key difference.
Excellent. Any thoughts around a little more specific around governance things, structures, committees, approaches that you've seen work, or anything you think might be problematic?
Yeah, I think governance is always a big important step to take. I think we've established, we actually are restructuring some of our governance now as well to include, to your point earlier, about to include more enterprise imaging components in it. So having stakeholders from the other imaging specialties involved as we make changes or propose new advancements in the system. So I think it's important for organizations to continue to have that, have governance in place, and that can be for imaging modalities themselves. It could be for the operations and the applications that are in the space, and obviously having some sort of AI governance in this space as well, because I believe over 75% of FDA-cleared software applications in AI are in medical imaging. So again, demand there is continuing to grow, and having governance around that, making sure AI tools and other changes are proposed to the enterprise imaging systems are ones that will truly add value to the system. I think that's a key thing that the governance committees need to be involved in. With all these outstanding requests and all the growth that's happening that I spoke about earlier, it's important to have some key stakeholders at the table to be able to review that, from IT security, subject matter experts, compliance and legal. We bring them in, ethics sometimes, especially with patient-facing tools. So all of those are key things to have in your governance teams.
Yeah, because when we're trying to, the dynamic you mentioned about a desire for consolidation, and it's a really interesting dynamic and a good point. So when we're consolidating, we assume that the goal is one. But that probably is not the correct assumption to some of the points you made. I think of the low-hanging fruit idea, meaning it could be, for example, it could be really easy and beneficial to get from 10 to 3, but then to go from 3 to 1 may be just not worth it. The amount, what you lose, what you're giving up. You see, it's real easy to get rid of 7, but then, so if you're not thinking the right way, you're thinking I have to get to 1, but getting to 3 may have just been wonderful if you just stopped there. Um, and then you mentioned the 80% rule, which comes up in a lot of discussions on the sort of the general application side when we talk about, you're an Epic shop. Most
Right.
organizations are on one of probably three EMRs. Uh, Everyone's trying to stay in suite these days. One of the common quotes is if you can get 80% from the tool in suite, go with it because you're going to pay a price going outside with integration work, cybersecurity, all these kind of things. You mentioned the 80% rule. But you can't have IT people making that decision. IT people are not going to say, "Hey, Doctor So and So, this tool you're using, I think you got about 80% of what you need here, so just keep using it." Like that doesn't work. It's got to be operations, but it has to be a decision where all these factors are taken into account and weighed. It's very interesting, and there's so much gray area. Your thoughts there?
Yeah, 100%. I think you hit a lot of main points. I think the key factor is kind of having that right culture and dynamic in your organization where, all those different stakeholders and can voice their, feedback and opinions and understanding because everyone is bringing something to the table, right? Um, I try to balance it between the IT stakeholders, which may, are key part of the decision, especially because they're going to be maintaining any applications and supporting it. So those are key components to take into consideration. Operations as well, so that they're involved in decision making because that's going to drive things around like analytics and efficiency workflows for the operations side. And then I do think physician stakeholders are very key. So again, very fortunate that at Emory we have physician informatics, and we have a seat at the table when making those decisions and can propose things to the organization that'll make meaningful change. But physician informatics can come in and also say, hey, this proposed change is going to have a detrimental impact on our physician workflow or efficiency that we have. So they can kind of have an equal voice at the table so that that's taken into consideration. So really important to have that culture and partnership. I think that's the key. That's going to be the key factor for any of these organizations, for whether it's enterprise imaging, decision making, or in general any clinical application support.
Excellent. I think of imaging. There's certain areas that you really have to know the operations and what's going on in those departments, and they're very intricate. I think of imaging. I think of even revenue cycle in a different sense. When we talk about the IT executives, the enterprise IT executives, they have to cover all those areas in a sense. And we used the term before that they have to lean in to learn, right? Because
Yeah.
most of them, a lot of them came up through infrastructure, networking, um, and they grow and learn. But you learn by leaning in. There's sort of the general operations of the hospital, general medicine. That's probably what you learn first, the general operations of patient care. But then there are these niche areas like imaging where you really have to devote yourself to understanding the workflows and the dynamics, just like revenue cycle. And I'm thinking how a health system develops a body of expertise. And I was thinking that you would probably have a dynamic where you have IT executives leaning in and learning the operations intentionally and politely and requesting to be included in meetings and spending time on the floor and just really trying to learn so they can support better from an IT point of view. But also, you have folks like yourself that are from the operations that are leaning the other way towards
Right.
IT, right? So it's fascinating, and you could have individuals meeting in the middle on these committees coming from either side, and I think that's probably where the magic happens. But you want an environment in a health system where both those things are happening. What are your thoughts?
Yeah, exactly. You mentioned that, and people come from different backgrounds, and I think that helps with their perspective on various things. Obviously, having a physician background and clinical background helps with making some of those decision points or understanding the nuances because we can kind of bridge the gap between having both speaking the IT language per se and the clinical language versus only siloed in one area or the other, and you may not understand what's going on or all the needs of what one side versus the other. So I think it is that harmonization from both parties and bringing those the stakeholders to the table. And I think you mentioned also as well how these are kind of more niche specialties, but I think for like radiology, it really is kind of underpinning every single thing that we're doing in healthcare, whether that's for acute care, outpatient, population health. Again, imaging is a part of that patient journey wherever they go. Lab is another example that has
Right.
specialty workflows as well, and it spans all these things, right? You can do a lot of stuff, that may be ingrained within Epic and EHR, but you're still going to rely on a lot of third-party solutions to be able to bring those connections and integrations together. So it's nice to have that, be in that space. That's why I really enjoy it. It's a good marriage. Radiology is a good marriage of that technical expertise as well as having that uh, clinical experience as well, because we're in so many different specialties and spaces, and there's constant innovation happening. But I think for the healthcare executives out there, it's really important to establish that culture and ownership of having experience in those specialty spaces and bringing those subject matter experts to the table, because they'll help. There's bidirectional learning that happens there, so you're able to learn from those stakeholders and what really the pain points are for the users, but then also understand, you'll know the complexities of what those systems take to maintain and support. So it's really important to have all those people in the governance and all at the leadership table to be able to make those decisions together collaboratively. And then finally, to be able to set the kind of strategy and innovation going forward so that your roadmap is clear and you're all marching towards the same goals at a long-term basis.
Is one of the challenging dynamics here the traditional dominance of radiology in imaging and the fact that when you move towards an enterprise approach, radiology is going to have to change some of the tools or some of the ways they work in order to accommodate more of an enterprise approach, and that can be challenging to get those kind of agreements and compromises. Is that one of the dynamics that has to be dealt with here?
Partially. I think it's a little bit the other way around, though. I think radiology has been in the space for so long that we have many established standardized practices, whether it's on the technical side with DICOM standards and HL7 integration, FHIRcast, all these sort of things that have been, very robustly, not necessarily purpose built, but really tailored and standardized around radiology imaging workflows. And then you have other specialties, whether it's, cardiac imaging, digital pathology, and others that are starting to, they may be more early on in their trajectory for adopting digital workflows. And so those markets and those specialty spaces are still kind of where radiology was maybe 5, 10, even 20 years ago, just starting their journeys.
Hmm.
But the nice thing is that radiology has those standards already in place, and they are being universally adopted for other specialties. I'll give the example of digital pathology. There's different ways that it's being implemented, whether they're using, DICOM imaging is one focus point versus using, their own proprietary potential imaging for capturing it. And so enterprise imaging strategy will look at it and say, hey, let's try to make sure that our digital pathology conforms to the same standards as radiology, and we can learn from our radiology counterparts on how to do that and do those integrations in such a way that it becomes universal. And so same thing happens for, heart and vascular imaging, or again, for visible light imaging and other places. So I think those specialties are quickly catching up, and they get the benefit of, having radiology having, worked through and maybe fumbled through different standards and implementations in the past. So it gives them also a jump start, just like we said at the earlier conversation, for security points for Apple devices and such. This gives all those other specialties a similar baseline for where to go and how to do these implementations and integrations, so that their specialties are set up for success. And then it allows radiologists to still be involved in the case, but then, I know the standards, for example, for radiology, and they become universally applicable, whether or not I know all the individual nuances for, cardiac imaging or digital pathology. I'm not practicing those things on a daily basis, but since I speak the same language and the radiology rules apply, you can translate those easily to the other specialties.
All right, excellent. We used you as an example of a clinician that's leaning into informatics. One of the other trends we're seeing is the called the rise of the physician builder. Um, Epic's got the agent factory. There's tools outside of that, but probably a
Right.
lot of people working within that. Do you consider yourself a physician builder, or is that something that you're thinking about or have seen come into play?
Yeah, so I've certified for physician building, and I've done that as well. We actually at Emory we separated out, and we have teams that are the physician informaticists who do have that certification understanding, but are primarily leading in the operation space and setting the tone and direction for our strategy and goals for the institution. So we're operating kind of in that leadership space, but have that technical background and may or may not have done building, active building in our environment. It just depends on that space. But we have a whole separate force of physician builders who again may not be at the leadership level, in setting direction and tone for operational strategy, but have certification build. We protect some of their time and they can get compensated for doing physician build activities, meaning, as you said, either building something out in Epic alongside with an analyst buddy, or other, it can be in other applications as well, using Epic as the example. But we have a robust, workforce for that internally within Emory, and that really helps accelerate a lot of projects that we have because again, they're someone that they know how to technically build the application or the request, and they have the clinical knowledge to know, yes, it makes sense to make this, flow sheet question, a binary question or a free text question because they understand what the downstream effects are for the actual clinical practice. So versus someone who is solely an IT analyst, they may not have that clinical context. They don't even know necessarily what the terms they are, putting in the question that they're building, but they're just kind of almost copy pasting the request from a clinician or responsible, service line. But having that as a physician builder in that space helps because that eliminates the knowledge gap that would have been there for a traditional IT analyst. And to your point, I think the agent factory from Epic, I've seen, demos of it, and we've, seen we've proposed different examples of how we want to implement that our institution. I think it's going to be another turning point with putting these types of AI agents in the space because it'll automate and accelerate a lot of things that have been held back traditionally by building rules or very strict requirements to be able to enable things. I think the agent factor is going to help unlock a lot of those use cases that we've been waiting on. And it sounds like institutions will be able to tailor it to their local needs, which will be another big win.
And would the are the physician builders are like reporting up to a CMIO type? Is that how it's
Yes.
structured?
So we have one of our physician informaticists and one of our clinical informaticists who is nursing background. So the two of them lead our builder program, which consists of physician builders, and we have also nursing trained that also have build certification are eligible for this as well. So oversee. We have at least 50 plus people who are certified in this space and are eligible. They get assigned, project tasks and requests, and they can be partnered with specific IT analysts to build things out in specialty apps. And then yes, those two leaders report through to the CMIO, and it's all part of our physician informatics and clinical informatics teams and work structure.
So what's next for you? What's on the agenda, that sort of the big ticket items you're looking at over the next 6 months? Any one or two things that are going to sort of take up most of your attention?
Yeah, I think some of the biggest things continue to be AI strategy and governance. We've caught up a lot, and it's become a more mature space in the past couple of years, but there's still a lot of forward looking that's happening to set what that strategy is. And we're getting to a point where we're looking at tools that we've previously deployed and trying those contracts are up and new innovations have come out. Trying to figure out if those are things we want to maintain, what has been the return on investment for those, and where do we want to position ourselves for the future state. And then additionally for enterprise imaging strategy, right, we're looking at continue with all the growth that we've had. Emory recently acquired two new hospital systems in Georgia, two new hospitals in Georgia. We're on a growth continuing to grow year over year, whether it's from not just from mergers and acquisitions, but also from organic growth and increased operational efficiency. So making sure that our radiology imaging and enterprise imaging is keeping up with that growth and set up for success.
So plenty to keep you busy.
Oh, yes.
All right. That's wonderful, Dr. Kikano. I want to thank you so much for joining me today. I really appreciate it, and I hope we can catch up with you again down the road.
Same. Thank you so much, Anthony, for having me. I really enjoyed it.
Have a great day.
You too.